All right, everybody, welcome to the Confluent Health Excel in Your PT Career series. We are well over, I think, 13 of these now total, past the year mark, and super excited for our June offering. I know a lot of you are interested in this particular topic of sports and treating the running athlete. Before we kick that off and introduce you to our speaker today, just want to give you a little overview of what we're up to in case you've never been to one of these before. Like I said, this is hosted by Confluent Health. Confluent Health is a family of brands across the U.S., primarily outpatient physical therapy, but we also have outpatient occupational therapy. We have speech language pathologists. We have a whole industrial division for athletic trainers and the industrial health side. And we have an education division in evidence in motion. So today, and what we're all about when we come together for these particular series, is bringing our expert PTs to the forefront to share their expertise in various areas. Confluent Health is made up of thousands of PTs, like I said, across the US and a bunch of different brands. And we also have the most board specialists out of any company in the US. The national average is about 11% of PTs are board specialists. At Confluent Health, we have over 60% of our eligible folks are board specialized. Today is no exception. We bring you Amy Clark. Amy is the Chief Education Officer at Sport Therapy in sort of the Dallas-Fort Worth area of Texas. Amy has an extensive background in teaching and learning. She has her doctorate of science and is also an expert in manual therapy, in physical outpatient therapy, and sports therapy. So I will let her introduce herself even further, but super excited to share her topic with you today. And again, that's treating the runner and the sports physical therapy or the sports physical therapist. As we're going today, if you have questions, throw them in the Q&A. So you'll see at the very top, there's a little Q&A button. Go ahead and toss those in there. Emily, who you can't see right now behind the scenes, and myself will be monitoring that as Amy sort of goes. And we'll have various moments, and definitely at the end, we'll pause and give you a chance to ask all of those questions. We'll also share contact info and all that good stuff in case you are interested in asking more questions or even coming to join us for a rotation or a job in the future. So I will pass it over to Amy and talk about some sports.
Thanks, Allison. I appreciate that. Thank you guys so much for hanging out with me tonight. I'm super excited to speak on this. This is my passion. As Allison said, I treat all orthopedic injuries, but this is kind of my specialty. And so I'll clarify a little bit more. I'm going to be talking about treating the endurance runner. So there is quite a bit of a difference between treating the endurance runner versus the sprinter and, more of your high velocity type of athletes. There's definitely some different nuances with that. So I will get started with everything. And like Allison said, if you have any questions, just jot them down in the Q&A and I'll be happy to answer those. All right, so first let's start by defining running. So big difference between walking and running. I'll just share a personal experience here. So you've got a picture of myself and my sister. I do a lot of running. I've been running for years. I run marathons and ultra marathons. My family always thought that I was crazy, and lo and behold, my sister decides she wants to do a marathon. She's not a runner, she's a walker. So we picked a marathon that had a time limit that was going to be appropriate for her to walk a marathon. I will start off by saying that is the most sore that I've ever been in my life after walking that marathon, because there is such a huge difference between walking and running. My sister afterwards, she's like, well, maybe next time we do this, you should train. So walking, the difference, and you guys probably know this from PT school, a lot of this is going to be review, some of this will be new, but walking, you're going to have periods of double float, which means that you've always got one foot on the ground. Running means, double support. Running is there are periods of float. So there are periods where both feet are off the ground. So I have a picture there on the bottom where you can see us walking. There's one foot on the ground. And then you can actually see up in the top left corner, you can see some air underneath both of our feet. And so we've got a period of float there. And so running, we kind of talk about it being a series of connected spring-like hops or bounds. And we're going to use that analogy quite a bit. The difference in running is there is a high loading rate. There's a lot higher joint moments and muscle demands. And then there's a high ground reaction force. So whenever we're running, we get up to about 2 to 3 times our body weight. The requirements of running. So we need to be able to have adequate shock attenuation. We need to be able to have adequate limb alignment and stability. We need to have pelvic and trunk stability, and we need to have good adequate foot alignment and stability. So how does running happen? So we talked about earlier just the spring-like mechanism. I think most people are really aware of the active mechanics that go into running. So that's, force that's generated through muscle contraction. But what gets lost a lot is the importance of the passive mechanics. A lot of our energy comes from stored energy. And so the more that we can optimize this, the less we have to rely on those active mechanics. So this is where form comes in, and this is where there's debate between should you be a forefoot striker, should you be a rear foot striker, and we'll go into that in more detail. But passive mechanics is the stored energy resulting in rapid energy release. So it's just like that spring where it's going to tighten up into a tight coil and then it's going to release. You're going to have that stretch reflex and that stretch shortening cycle. I'm going to skip this video for now. And then go into defining what running economy is. So running economy is just a measurement that we use to measure the cost of running. It's one of those, it doesn't have an actual metric, but there are things that go into making this running economy. It breaks down into 3 different things. We have biomechanical efficiency, we have neural efficiency, and we have metabolic efficiency. The difference in those is biomechanical efficiency is the mechanical cost of running and includes factors such as energy storage and how wasteful the movement pattern is. So this is where we'll really get into form. That's going to go into our biomechanical efficiency. Our neural efficiency is the improvement in the communication between the nervous system and the muscles themselves. So this is where we're strengthening our muscles and we're going into the motor patterns. And then we have metabolic efficiency. Factors that impact the production of energy for the muscles to use, such as fuel source or oxygen delivery. So this is how well we're able to convert carbs into energy. And everyone, I don't want to give anyone PTSD, but going back to our Krebs cycle and all of our breakdown, that goes into our metabolic efficiency. And that's one of the things that we train in order to become more efficient runners. So we want to find a balance between those 3 parameters. What you'll find in your runners is oftentimes they're going to be really dominant in one area. And so you kind of have to cue in not only on what's going on biomechanically with them, but you have to be able to cue in on those other factors as well. So when you have your runners come in, you're not just looking at, their strength and their range of motion, but you need to find out the whole story. What led to the injury? Is it more because of something that's going on biomechanically? Or is there a breakdown in a muscle? Is there a muscle weak? Are there asymmetries? Or is it, that metabolic efficiency? Are we not fueling correctly? Are we not breaking down our carbs in a more efficient way that we can use for energy? The balance between these 3 parameters will give us an optimal RE score. And this is a really hot topic right now. There are lots of podcasts right now where they're really looking at how these 3 factors play in. And you'll have people that will, speak highly about the biomechanical efficiency. And then you'll have people that, oh no, it's all about the neural efficiency. But it really is that balance between the 3 different parameters. So it's possible to become more efficient in one area, but have a total RE that can be negatively affected because of a larger decrease in another aspect. I don't know how much you guys actually follow professional running, but you'll see some of these professional runners and, super fast and breaking records. And you'll look at their form, you're like, oh my goodness gracious, their form is awful. They've got a medial whip or they've got knee collapse. But because they're so strong in these other areas, they can get away with that. So more into running economy, things that affect it. Our genetics play a big role. Okay, we all know we're not all built to be professional runners. Metabolic efficiency. Can we turn our systems quickly and turn them into nutrition, into energy? We talked about that earlier. What is our VO2 max? That's a really hot topic in running too, and that's going to kind of get away from what I really want to talk about. But VO2 max is a measurement that we use for our power sports. It's somewhat important for endurance running, but really it's just that ceiling effect. We want to have a high VO2 max just in order for us to be able to have a higher lactate threshold. And again, I won't get into that because that's kind of another topic, but that does affect our running economy. Our running style is surely going to affect it. And then, of course, our body type, our strength, and our motor programming, and then our training. So again, when your runners come in, make sure you're asking them about our training, because the most common thing that leads to injury is not necessarily their form. Our bodies can adapt to abnormal forms. Again, we see those pro runners that just have, incredibly horrific knee collapse and lateral and medial whips. But their training is optimal. They're not doing back-to-back hard runs. And so do find out from them, what does your training look like? Because usually that's what's going to lead to our injury. So breaking down those three factors, our biomechanical efficiency, this refers to anything that impacts the mechanical costs of running. So our passive dynamics, this is our spring effect that we talked about earlier. More active mechanics will happen through our neural and metabolic efficiency. So biomechanical efficiency, we're really looking at those passive dynamics. If we can optimize these factors, then that actually results in less energy. So we really want to talk to them about getting their feet underneath them when they're running. And we'll go into form later, but we want to kind of factor in on these passive mechanics. So for example, that's that elastic energy storage and return, mechanics of the stride itself, how the foot lands, which is a big topic out there, and the structure of the runner. We can't deny, the structure of the runner. Are they tall and lanky? Or they short and lower to the ground? Those factors are going to play a role in this. So the stretch shortening cycle and the elastic return, this is muscle that's actively stretched and then it immediately contracts. That's your spring. So we store that energy and then it's immediately going to contract. Our energy is stored during the pre-stretch and it's released during this contraction. It's dependent upon the length and the speed of the stretch. So that's our plyometric training. So how quickly we can go into that stretch position and then come out of that stretch position. We want to rely a lot on stiffness of the muscle. How many times do you see your endurance runners that are actually flexible? We've kind of gotten away from really stretching the endurance runner because of this energy storage. We want them to have the availability to store that energy. So sometimes we don't overemphasize stretching out those hamstrings. Your runners, I'm sorry, they're just not going to have really loose hamstrings. They're going to have tight hamstrings. And then what's the time between the stretch and the subsequent contraction? So that's our jump test. As soon as we land, how quickly does it turn into a contraction? And this is going to rely heavily on a person's biomechanics. So whenever I'm talking to my runners about being efficient in this area, I'm talking to them about landing with their feet right underneath them. I tell them whenever they're running, I always give the analogy, if you're helping your friend move furniture, do you want to, if you're picking up the couch, do you want to be on the pushing end or do you want to be on the pulling end? We all want to be on the pushing end, right? It's a lot more work to be on the pulling end. And so that's the same thing with running. If we actually get our feet landing underneath us, then we're actually able to propel ourselves forward. But if you imagine the overstrider, and we'll have pictures of this in a minute, that foot's going to land in front of us and we actually have more of a pulling moment. And so that's not very efficient and we have to work a lot harder to propel ourselves forward. So how do we maximize it? Again, the big debate, does foot strike matter? And we'll go into that in detail in a minute. Plyometric training. I gave this talk a couple of weeks ago to my running group, and I have a lot of older runners. And so my question to them was, at what age do we quit doing plyometric training? And I was so proud of them because most of them said never. But that's a big misnomer, is a lot of folks think that whenever you're older, you can't jump. I think that now we're getting so good with our geriatric training and we have our older adults actually doing safe plyometrics. And that's the same thing here. If we're going to ask people to go out and run, that is a plyometric movement. So we need to be able to train that. We're going to do sprints and strides. And then what about running surface? Somebody asked me today, is it safer to run on gravel than it is on grass, or which is the best surface to run on? And my answer is always, well, it depends on which research you read. There's some research that says it doesn't matter the surface, ground reaction forces are the same, but then there's some research that does show a difference. So our foot strike, here's the differences. So if we have more of a forefoot strike, we're going to have a lower vertical loading rate. We don't want a bunch of wasted energy. We don't want bouncers whenever they're running because that's wasted energy. We want to be able to propel ourselves forward, and having more of a forefoot strike will allow us to have more of that lower vertical loading rate. It's going to give us the potential for increased energy storage in return. So imagine you're landing on the front of your foot, your heel is likely going to hit the ground, and then as soon as that heel hits the ground, then you're able to propel yourself forward with that energy storage. We'll have the potential for a greater strain on calf complex. So I do warn all of my runners whenever I never throw out there, hey, you need to be a foot striker or a forefoot striker. I don't do that. Instead, I kind of let it happen naturally. I usually play around with their cadence and it happens naturally, but I do warn them whenever they do start running more on the front of their foot that they are going to have greater strain on their calf. So you do need to watch this. They need to make sure that they're staying on top of their calf raises and strengthening, and you don't want to implement it too quickly because that can lead to a calf injury. They're going to have shorter ground contact time too. I always tell my runners, the longer your foot is on the ground, the longer time you have for injury, because we rarely get injured in the float stage of running, right? It's usually more whenever our foot is on the ground. So I tell them we got to get the foot off the ground quickly. So you have a potential to have that shorter ground contact time if you are more of a forefoot striker. Rear foot strike, we have an increased risk for tibial stress fractures, and I've got a great picture later that's going to show why this is. And we're going to have increased extension at heel strike and at mid stance with the potential to increase shock at the knee. So if you've got someone right after ACL reconstruction or right after a meniscus repair and they're hitting on the back part of their foot and they're increasing the extension at their knee whenever they're hitting on the back of their foot, that's going to be potentially damaging to their knee. So we may have to play around with that just a little bit. They often overstride, and this is the potential for increased knee injury as the knee goes beyond the toes in stance, and I'll have a picture of that too. They're going to have longer ground contact time typically. So here's a great picture of someone that lands with their foot underneath them. Whenever I'm doing a gait analysis on folks, I like to draw the line. So if I have a line that drops from their shoulder down to their foot, I want their foot to land right underneath their shoulders. So you can see he's got a slight hinge at his hips. He's got a great flexion angle at his knee. We kind of call that athletic stance. It's not too extended. It's not too bent. It's a nice compliant gait that he has there. And then you see the guy on the other side that's landing with the foot way out in front of him. So that's going back to pushing and pulling the couch. So this guy's landing with his foot out in front. And so in order for him to propel his body forward, he's going to have to really use those hamstrings more. He's going to end up locking his knee more whenever he goes into mid stance. And then he's going to have that pulling mechanism as he propels himself forward. Running misconception. We give lots of drills to our runners. We focus on drills for knee up, arm swing, butt kicks, pawing the ground. And I'm not saying these are wrong, but I think we need to think what we're trying to accomplish with this. We just talked about the importance of passive energy. And so if we're really relying on passive energy, then we don't have to focus as much on the drills for knee up, arm swing, butt kicks. Again, they play a good role, but I think that sometimes it gets overemphasized. We want to, make sure that we're incorporating drills to help us land with that foot underneath us. All right, the next one is our neuromuscular efficiency. So factors that improve the muscle force production itself. factors that improve neural signaling and motor programming. What this is practice, practice, practice. The more you do it, the more our body adapts to it. Our bodies are really smart and they'll pick up on these motor patterns, but we have to do them repetitively. So this is where we put the runner on a treadmill. We tell them the things to focus on. We put them in front of a mirror and we say, watch this. And we let them do it first in front of a mirror and they practice, 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 do it over and over and over again. And then we take that mirror away and then we hope that they're able to still have that same motor pattern whenever we take that feedback away. A study showed that novice cyclists will have greater variability between muscle recruitment between pedals. There's more variations of recruitment between each individual, more muscle co-activation, and longer muscle activation periods than well-trained cyclists. So what does that mean? They're finding that in novice cyclists, they're not having that predictable motor pattern. So there's more discrepancy in how it's happening. Their body hasn't learned to adapt to that same motor pattern. So general adaptation syndrome, if you don't know anything else, we know that we want to teach the body to adapt to things. That's what physical therapy is all about. We teach our older patients whenever they're going from sit to stand, whenever they're walking, using their walker. We want to be able to adapt to different stresses. So the 3 phases of this general adaptation syndrome. First, we have the alarm stage. So the body's alarmed. The body has an immediate response of fight or flight. So it's new to them. So what does the body do with that information whenever it's something new? We're going to have resistance to that. So the ability to adapt to stressful situations and actually become stronger. I always tell my patients whenever they come in, they say, well, I can't do that. Well, I wouldn't ask you to do something that we know you can already do, right? We're going to teach your body to adapt to new things. And then exhaustion is if we have that high stress level for too long of a period of time, then the body will begin to break down. So we need to find that sweet point. The risk factors for injury, we're going to have intrinsic factors and we're going to have extrinsic factors. So intrinsically, we can't control this stuff, okay? Older age, you can't control that. It is what it is. Our general health and our increased BMI, that's going to be an intrinsic factor. Is there a history of prior injury? This is actually one of the biggest precursors to injury is history of a prior injury. If they have abnormal anatomical alignment and foot posture, that's intrinsic. But other factors that are extrinsic, running experience, weekly mileage and or intensity. So like I said, we need to be asking them about their training, their abnormal mechanics, equipment gear, and their training surface. So age, what happens whenever we get older, our cardiovascular system, it's going to be influenced by plaque buildup over the years and genetics. Our respiratory system, we're going to have a decreased VO2 max. We're going to have decreased elasticity of lung tissue. Musculoskeletal, we're going to have bone loss. We're going to have decreased muscle strength, and we're going to have decreased flexibility. We all know this stuff. Our nervous system, we're going to have decreased balance. How many of you have had the opportunity to work with individuals and they're shocked at how bad their balance is? It's they don't realize that as they get older that we've also have to work on our balance. We know that we've got to work on our strength. We've got to work on our mobility and our cardiovascular system. But I think it's always surprising that, we lose that ability to balance as well. And we have decreased coordination. Our reaction times are longer. General health will play a big role, so increased BMI, and even sometimes more important is our self-perception of weight. We know whenever we get into red syndrome, self-perception of weight, we've got very common in the endurance running community, body dysmorphia and just not taking in enough calories and running into that red syndrome. What are our eating habits? Are they on a special diet? We've got folks that are doing the ketones, and we've got folks that are doing vegan. I'm vegan, so that plays a role in how I have nutrition for running. So ask them about that. Are you getting enough protein? Are you getting enough carbs? Are you fueling at the right times? Bone loss, whenever we have more risk for bone stress injuries, A lot of times it comes down to they're not fueling at the right time. So we have to get those carbs in whenever we're doing our running, because that's how bones really rely on carbohydrates. So if we're not getting enough carbs in, then we're more at risk for our bone health injuries or bone stress injuries. What are our sleep habits? Sleep is really important. What happens whenever we go to sleep? I always have this conversation with our runners and make sure that they know the importance of sleep. And this is really big in especially your adult runners with kids. They'll get up early in the morning to knock out their run. Well, what's going on with their sleep? They're probably still going to bed at 9 or at 10 or 11 o'clock, and then they're getting up at 4 or 5 in the morning, and they're not getting adequate sleep. And so they're missing out on these really important factors that happen at night. So we need that growth hormone that's going to stimulate that cell reproduction, growth, and cell regeneration. This is what's released during our rest and sleep. And then we all know the importance of cortisol and how it can affect us. This is released during stress and whenever we have a lack of sleep. Cortisol may suppress the immune system. We're going to have more inflammation if we have high levels of cortisol. And then, of course, stress is going to play a big role in that. History of similar injury. Tissues heal. I think I stole this from our pain science course. But this goes to show, I think that this is really interesting too. We talk so strongly about how you're healed. Well, what does healing mean? This has a picture of a hamstring that was injured, and you can see all the inflammation that was there 7 days post-injury. Then you see the healing that goes on 2 months after injury. But look at 7 months post-injury, there's still indication of there being an injury there. When we heal with different collagen than the original tissue. It's more brittle. It's not as forgiving. It's not as elastic. So that just sets us up for having more potential for injury. And not just injury at the same site, but when we have an injury in one area, our body's going to learn how to compensate in other areas. So it's not just that if this guy has a hamstring injury, we're not just worried about him re-injuring his hamstring, but we're worried about compensatory effects and injuring other areas. Abnormal anatomical alignment and foot posture. I'll tell you guys, I graduated in the days where we took lots of static measurements. We would put the patient in prone, and we would measure their foot angles, and we would look at how much varus they have, how much valgus they have, and we really made a lot of predictions based off of that. But that's kind of gone by the wayside. Sometimes I think it's important for things like making orthotics. So I do orthotics, and I'll still look at some of that stuff. It's not my main deciding factor, but it may play a role in what I'm doing with orthotics. But we've really gotten away from looking at those static things. Our runners will go to these running stores and they'll stand on these foot scans, and these foot scans will say, oh, well, you've got a flat foot, you need to be in this type of shoe, or you've got a high arch, you need to be in this type of shoe. Okay, but what does it look like whenever we actually add gravity to this and we're actually running? So many times I've seen runners that have a high arch that still overpronate. There's a lot of factors that go into that. If we have poor hip mechanics, that's going to travel down the chain and lead to overpronation. So don't just rely on what you see whenever they're standing. It is important. So if we've got someone that is standing in a natural sway back or is standing in a natural thoracic kyphosis, that is going to play a role, but it's not the deciding factor. What is our running experience? So what some of the literature is showing is our novice runners are 2.5 to 3 times more likely to be injured, but they're also more likely to quit running after an injury. Well, running's just not for me. I guess I'll just give up. Whereas our competitive experience runners, they're more likely to ignore symptoms. So which one is more likely to get injured? It's a toss-up, because our novice is going to be more in tune to listening to things and having that oh, I shouldn't do this, this hurts, more fearful type of activity, whereas our competitive people, like I say, are more likely to ignore it. And as I said before, what is their weekly mileage or their intensity? And not just what their weekly mileage is, but what that intensity is. So when you ask them how many miles they run per week or how many miles they're running at a time, also what type of workout is it? Are we overloading the system? Are we underloading the system? What happens during those moments? Whenever we're running, we're building mitochondria. We're building those new efficient vessels to working muscles. So like I said, our body's really smart and it learns how to adapt. And so we'll actually start laying down new pathways. We'll build new capillaries to the working muscles. So when we start to run, we're going to have only so many muscle fibers that we're going to select from. We've got pathways that will go to so many muscle fibers, but the more we start to do that, the more we start laying down these capillaries and we're able to recruit more and more motor units at that time. And so we become stronger just because of more motor units that we're actually recruiting. So it teaches the body to work for longer periods of time on tired muscles. Um, and then faster, tougher workouts. What happens during our faster, tougher workouts? The body's going to break down muscle microscopically in order to rebuild new, stronger muscle and collagen. So I tell people, this is what happens whenever you're doing a hard workout. We get stronger because we're stressing the system. Our body's actually going to break down. And then when we go to bed at night and we have that good rest, we've got growth hormone that's going to help stimulate new, stronger muscle and collagen. But this is going to take a little bit longer to recover from. If we have those easy runs where we're just building those mitochondria and we're building those pathways, we can recover from that a lot sooner. Whereas when we're doing these tougher workouts and we're breaking down those muscles to a larger degree, it's going to take longer to recover from that. And this, like I said, can be inhibited by poor sleep and or nutrition. So if we're not getting that good growth hormone and we've got too much cortisol and we're not getting the right type of nutrition, we're not getting enough protein, we're not getting carbs at the right moments, this is going to inhibit some of this recovery. The Goldilocks principle. So I have a lot of runners and it's not just with runners, but it's with all of our older adults, our weekend warriors. They think that they're safe because they're only doing these activities on the weekend. So I'm not running during the week. I'm just stressing my body on the weekend. To me, that's just as detrimental as doing too much activity. So this is what our Goldilocks principle looks like. We've got a training stimulus, we've got our super compensation, we've got our recovery time, we've got our fatigue. And then look at the lines there. We've got the yellow line that is actually too little, so we're not doing enough. And then we've got our red line, which is too much. Both have the potential to end up in injury. So if we have our runners that are just doing activity on the weekend, they're not building those adaptation, they're not building those new capillaries, and so they're just as high a risk of injury as our folks that are doing too much. Abnormal alignment and foot posture. I love this picture. I stole this, but it's a great picture to demonstrate the importance of strengthening our foot muscles. So postural variances within the body, muscular weaknesses, inflexible muscles, poor motor patterns, and the wrong type of running shoe. And then another factor that will play a role in this is our equipment and gear. I love a lot of people get into running because it's an inexpensive sport, but I love this meme because getting ready for your simple and inexpensive sport, we spend so much money on the gear. Running shoes are so fancy now. I always tease, and if I'm having a day where I'm super fatigued, I'll put my carbon plate shoes on and go for a run. And I'm like, I just need my shoes to do the work for me. But it's true, we have shoes that are more efficient. And so equipment can play a big role in that. Not just our shoes, but we're spending lots of money on watches and just all do we wear compression socks? That's always a big topic. Is this going to be helpful for me if I wear compression socks? Is that going to prevent me having shin splints? So again, sorry. I put really sometimes inappropriate memes in here, but just an example of if you feel good and whenever you're wearing the right type of equipment and gear, then a lot of times that leads to you having a better workout too. So I do think it's important to make sure that your activewear is on point. Shoes. This is really interesting because, when we're doing gait analyses, a lot of times we're looking at what's going on with them barefoot. But shoes can actually turn into increased pronation. So make sure that you're looking at different types of shoes that they're wearing. Again, getting into these new shoes that have the carbon plates and have the higher stacks. Um, these can sometimes lead to increased pronation. Get out there and watch some of these runners that have these high stack shoes on. You're going to see, because of the stack height, you're going to see them fall into pronation, or you're going to see them fall more on the outside of their foot. So make sure that you are taking this into effect. It can change your mechanics. Going back into their training surface. So again, it's debatable. Whose research are you reading? Some of the research will say, though, going from best to worst, it's best to run on grass and then dirt and then rubber track, asphalt, and then cement is the lowest. I put a picture up there. I do a lot of trail running too. We've had a ton of rain up here at some of our trail races, and so our trails will turn into this muddy mess. That is not a good training surface. So I would definitely put that below cement. So what are our takeaways from this? So our key ideas to preventing injury: warm up properly. We want to have caution with high volume increases. I'll tell people too, we need to have a base before we start any kind of speed work. So our runners will get super excited. We're starting a new running program. So we need to do all the things. We need to do strides. We need to do 400s, but we need to have that good base before we start proper speed work. So I'll tell them, start with only 1 day per week of a quality workout. And that quality workout will either be speed or hills. And then we want to have gait improvement. So do that gait analysis. Are there things that we can make them more efficient? Make sure that we're scheduling rest. Make sure that we're cross training. We're doing our resistance training and listening to our body. So pain versus soreness. We know that there's a difference, but our patients oftentimes don't know that there's a difference. So teaching them the difference. Soreness, I tell them soreness will go away 1 to 3 days after a workout, and it usually feels better once you get moving around. Whereas pain will have a different quality to it. Pain is typically sharp. It'll linger greater than 3 days, or it may be worse than during movement. I use this rule of thumb. If we have pain with 3 workouts in a row, maybe we need to get it checked. So pain in the same area. If you're experiencing anterior shin pain, 3 workouts in a row, okay, well, now it's time to see if something's going on. If we felt it during one workout, that's probably our body just trying to adapt. No big deal. But something that turns into we're feeling it every time we go to run, we need to look at this as something that may be more of an injury. So if we do have an injury, what do we do? Do we tell them you've got to stop running? I had a PT that used to work with me that wasn't a runner, and we would go to all these running events, and we would do these free little analyses. And his advice to all the runners was, you just need to quit running. It's like, you can't say that to them. They're not going to stop running. And sometimes complete cessation of running is actually detrimental. We've spent all this time building up these adaptations. If we tell the runner, okay, you cannot run until you're completely pain-free, we may lose some of those adaptations, and then we're having to rebuild, which sets us up again for more risk for injury. So we need to determine, do we just modify their activity, or is it at a point that we need to completely stop running? So different modifications that we can do. We can decrease their intensity. Maybe we completely take away their speed work. No running heels. Maybe we need to decrease their mileage. Maybe we need to ask that they don't run on non-consecutive days. You need to give yourself more recovery between days. Maybe we need to do some cross training. Definitely, if we ask someone to stop running, we want to make sure that they continue doing something. They need to do some type of cross training. And then whenever they return from injury. So different rules of thumb that you can use whenever they return from injury. If they're currently not running and they're at a minimal fitness level, this is going to be a slow build. They need about 3 to 4 months of easy running before we start adding any intensity. However, if they have prior running experience, so say you've got someone that's been running for years, they've taken some time off due to injury, we can probably progress them a little bit quicker. But still have that break-in period, but it doesn't need to be 3 to 4 months. Typically, they're able to adapt quicker and they're able to start getting back into higher level activity within 2 to 4 weeks of easy running. I learned this in school. I don't think that they teach this now, but I still like this as a rule of thumb. This was the Kennedy laws for modification. Um, it's not a rule that you can. It's not a solid concrete rule, but it's a great way to put it on them and say, okay, when do you have the pain? This gets into our SINS level. What is their irritability level? Is it pain only after running? If it's only pain after running, then I usually ask them just to decrease their activity by 25%. If they have pain at the beginning of a run and at the end of the run, I ask them to decrease their activity by 50%. If it's pain throughout the entire run but doesn't alter their gait, again, I'm not going to take running completely away from them. I want them to keep some amount of running, and it may not be running on ground. We may get them on the anti-gravity treadmill and have them still do some running on the anti-gravity treadmill. But I think at that point, it's fair to say decrease their activity by about 75%. However, if there's pain that is altering their gait, we're going to stop running altogether. But when they're injured, we're going to encourage them bike, swim, do whatever they can to keep their fitness level up so they're not starting from zero whenever they get back into running. You guys are learning rice versus peace, which I love this. All of our folks still, most of our folks are still, we need to rest, we need to ice, we need to do compression, we need to elevate. However, we're starting to say, well, maybe we don't ice now. Maybe that does slow down our healing period. Inflammation is important for us this first few days. We need to be able to go through the cycles of inflammation before we start laying down new tissue. So I love peace. Peace is protect, elevate, avoid anti-inflammatories, compress, and education. This is a runner's knee that fell on it and ended up with this huge contusion. So rather than ice, we did KT tape. KT tape was just a nice way of encouraging, more lymphatic drainage. So it was a way to allow the body to still go through the inflammatory period, but to help it move along a proper pathway. Resistance training. How many times do we hear runners say, well, I don't need to do resistance training for my legs because I already run and so they're already strong. So I tell people we don't want to I tell them change it from run to get fit. That's how a lot of people get into running is they want to get fit. But at some point we need to change that to be fit to run. So we need to do our resistance training so that we are fit to run. We look at other sports do resistance training. Our baseball players, our volleyball players, everyone's doing resistance training. Why would endurance running be any different? The majority of endurance runners have pronounced muscular imbalances, weak core and upper body musculature. So do those assessments. Where do we have those asymmetries? Where do we need to make sure that we're focusing that strength training on? And it can help to maintain that lean muscle mass. A lot of times folks are afraid if we lift weights, we're going to get big and bulky. Actually, it's the opposite. If we're doing the right proportion, it can actually help maintain that lean muscle mass. And when we have good lean muscle mass, the more muscle we have, the more carbs we're actually able to store. Glucose gets stored inside of muscle. So we want to have that good lean muscle mass so that we have the availability to store more carbs. So what types of training do we do? We're going to do corrective. So if we notice that there's any asymmetry, we're going to correct those asymmetries. We're going to do sport replication. So what are the mechanics of running? How can we replicate that and make it an exercise? We want to increase power and we want to increase overall strength. I love this. Cardiovascular fitness precedes musculoskeletal readiness. So what happens? Cardiovascular system adapts to training faster than the musculoskeletal system. So we may be able to adapt to running 20 miles cardiovascularly, but that doesn't mean that our muscles, bone, and connective tissues are ready for that. It's going to take a longer time for them to adapt and to become stronger than our cardiovascular fitness is. So what are the components of resistance training for runners? Like I said, we're going to have corrective that's going to target specific muscles, our sport replication, and our increased power. We do want to do those plyometrics. We want to emphasize that passive energy system, which is going to happen through our plyometrics. And then we want to increase strength for our active mechanisms. Our resistance training protocol. Again, we want to train. There's some muscles that are more endurance muscles. Our calves are more endurance muscles. Our quads are typically more power muscles. So I said 2 to 3 sets of 10 to 15 reps, but it depends on what we're going for. So we know with our strength, if we're trying to get true strength gains, we're going to do higher loads and low repetitions. I love seeing out there, the professional endurance runners that are in the gym and they're doing heavy squats. And that's something that, even a decade ago, you wouldn't have seen your professional endurance runners in there doing heavy loads. But now we're learning the importance of actually stressing the musculoskeletal system in this way. But we need to train the endurance aspect of it too. So low loads with high repetitions. But then we need to take other things into consideration. We know tendon loading. For tendon loading, if we want to lay down new collagen, again, we're going to do high repetitions to lay down that new collagen. But then we need to remodel that collagen. So we're going to do our eccentric training to help us to realign that collagen as we start to lay it down. And then our neuromuscular recruitment endurance, what did we say earlier? Practice, practice, practice. So we're going to do a lot of that. We're going to do a lot of drills, especially after we do our gait analysis, and there are things that we need to address with their gait. Practice, practice, practice to get that neuromuscular recruitment and endurance. Running form. So this came during COVID. This was one of my favorite memes. The guy walking in, and then he realizes he's got to walk back to his car to get his mask. So running form, we're going to use that spring mechanism. So you've got the guy on the left there. You see he's getting his feet underneath him. And so he's actually able to use that passive system and that spring mechanism by propelling himself forward. Whereas what we saw earlier, same picture, same story here, the guy is landing, he's more upright, which leads to more overstriding. So whenever he takes off and he has that spring mechanism, where's the energy going to go? The energy is going to go up rather than forward. So that's a lot of wasted energy. Arms, what do we talk about with arms? We want to avoid tense shoulders. Hips, we want to have that vertical alignment. And I'm not going to go into too much detail with that because we can have our robot runners and we can say, you need to be like this, you need to be like that. But we have kind of gotten away from having the robot. Everyone needs to have their arms bent at 90. We need to have the relaxed shoulders. Those things are important, but take it into consideration with the whole picture. So going into what common run form mistakes are, we've got our heel strikers, we've got our overstriders. We're going to look at the hip drop or the narrow window. We're going to look at our swingers. So what are our swingers? That's the people that swing the leg to the side. We see this all the time, the people that are swinging their legs from one side to the other and doing the little half circles. Then we've got our bouncers. So the picture that we saw before where the guy is more upright, he's going to be more of a bouncer. And so it's a bunch of wasted energy. And then we're going to have our high kickers, so runners who kick too high behind their bottom. So we'll get into a couple of pictures of that. But first, I love talking about shock attenuation because this is something that you're going to see post-op a lot. Stiff versus compliant. We talked about that knee angle, that nice athletic stance. That's what we call more of a compliant knee. Whereas we're going to have the folks that are a little bit stiffer whenever they're running. So whenever they're in mid stance, that knee is going to be stiffer. We're going to see this a lot of times after our knee surgeries because they don't trust their muscles yet, or they may not be strong enough yet. And so they're going to rely more on that passive stabilization. So their knee is going to be stiffer. But what stiff attenuation is going to lead to is landing with less hip and knee flexion. When we do that, we're going to rely more on bony cartilage and footwear. So the injuries that we see from someone that's running with their knee too straight in mid-stance, these are the folks that are going to have more of our meniscus injuries, more of our cartilage injuries, more of our early onset arthritis. Whereas our compliant people, people that have too much knee flexion, they're going to land with increased hip and knee flexion. They're going to rely more on muscle actions. And so these folks are going to have the potential for more muscle injuries or tendinopathies. So here's our heel striker again. He's got increased ground reaction force by landing with that foot in front of him. He's got poor shock absorption. He's got increased muscle activation from the anterior lower leg. And one thing I'll just as a little pearl, whenever you're doing your gait analysis with people, look at not just the bottoms of their shoes, but look at the top of their shoes. This is a really cool clue that you may find. Some of your folks will have a hole in the top of their shoe, and you do their gait analysis, and this is what you're going to see. You're going to see that their toes stay extended throughout the entire swing cycle, and then they're going to land more on the back of their heel. So they're constantly keeping their foot and their toes up in extension. And then that's going to increase the stress at the knee. So whenever you land with that foot out in front of you, you're going to land with that knee is going to be a bit stiffer. And then we all know our Trendelenburg. So we see the runner that whenever she's in mid stance and that hip drops. And then we'll show in a little bit, the other compensation that we get from weak glutes. Our crossover sign. So when they're running, the faster we go, the more we're going to land with our feet in a narrow stance. So our feet are going to eventually get to where they're landing close to one foot in front of the other. But we've got some folks that actually cross one foot over. So get them on the treadmill, put a line on the treadmill, and you see the picture on the right. This gal is actually landing, she's crossing over there on the right. And so what happens when she crosses over? I love that she wore that jacket because you can see what the line is doing there. So you can see that she's compensating, she's got some hip drop, and then she's also compensating with a little bit of rotation and side bend. And then we've got the guy that's got excessive foot pronation. Foot pronation can either come from the rear foot or it can come from midfoot. So whenever you're doing your gait analysis, you need to look from the back, but you also need to look from the side. This guy's got navicular drop. We're also going to use that same guy there. Now we've got knee in front of the toe. So I always use the example of when you're squatting, what happens when you're squatting whenever the knee comes past the toe? Potential for increased anterior knee pain. Well, the same thing whenever you're running. So if you're overstriding and that knee goes past the toe, then we've got increased pressure and ground reaction forces that are happening at the knee. And then we've got the increased foot ankle angle. Again, they're landing on the heel. We've got increased contraction of the anterior muscles, and then we've got that increased ground reaction force. And then the trunk upright. If we run too upright, we tend to overstride. We've got the peekaboo toe here. So I still use the too many toe sign. That was something that we learned way back in the dark ages, but I still use that whenever we're running. We like to see the 1.5 toes on the outside. And we can see in this runner, we can actually see her big toe. So what does that mean? Does that mean that she's got increased anteversion at her hip? Is she internally rotating at her hip? Is it coming from the knee? Is it coming from the tibia? So we've got our first clue, but that's not the end of the story. So after we see that peekaboo toe, then we've got to break that gait down into, is this coming from the hip? Is it coming from the knee? Is it coming lower in the chain? And then anterior pelvic tilt. I see this a lot in our female cross-country runners. They will use, if they don't have adequate power from their glutes and their calves, what they'll do is you'll see them really throw that elbow back, and then they're going to have an increase in the anterior pelvic tilt. So I'll draw a line from their PSIS to their ASIS, and we'll look at the angle there, and you can see how much of an increase that gentleman has in his PSIS to his ASIS. And then because he has that increased lordosis, we'll break down those lines even further. And you can see how he doesn't have good hip extension. So all of that motion is coming from that anterior pelvic tilt. again, which came first, the chicken and the egg? Is the anterior pelvic tilt causing the decrease in the hip extension? Or is it we have really tight hip flexors or stiffness in our hip that's leading to us having to anteriorly tilt our pelvis to get that power? And then the no window. So we should be able to fit a fist between the knees whenever they're in mid stance. This has no window at all. So again, that's part of the story. Then we have to look at what's leading to that story. Does she have a Trendelenburg and she's got some glute weakness, or is she getting some internal rotation that's causing that? Or is it coming from below at the foot and it's traveling up the chain? And as I said earlier, where's that rotation coming from? If you zoom in on this gal's knee, her rotation is actually coming from the knee. So I like to call this the knee pit. When we have the back of the knee, we should equally see the medial knee and the lateral knee. But you can see here, we see more of the medial knee. We see very little of that lateral knee. So where's that rotation coming from? That rotation is most likely coming from her hip that's traveling down to her knee. If she was pretty normal alignment there, and she still had some collapse, then we'd say that collapse is probably happening from lower in the chain. And then here's a guy that has glute med weakness. I swear, I don't tell them to wear shirts like this, but again, this is perfect that he has this shirt on. He has the writing on the back of his shirt. So usually I have them tuck their shirt in. I was really bad this day and didn't have him tuck his shirt in. But since he had all the writing there, you can still see what's happening there. He's on his right side, so instead of him having a Trendelenburg, you see how he's actually leaning to the right. So that's the same thing. That usually comes from glute med weakness. And then we have the abducted foot. So we have the person that as they're pushing off, their foot will actually go into more pronation. These folks will tend to get more stress fracture in their midfoot. So they're getting those stress, the kind of the torsional factor at their midfoot as they're trying to push off. They don't have adequate push off coming through their big toe. And so they're going to force their foot out into abduction, and that's going to create a lot of torsional stress in the midfoot there. And then here's our forefoot strike that leads to overpronation. So just because we're forefoot strikers doesn't mean that we can't overpronate. We had a forefoot striker here, and then you can see how much she collapses. This one has a lateral whip. This patient I was treating for posterior tib syndrome. And so every time she went to push off, she was in this inverted position. And then it's not just knee collapse, but sometimes our glute weakness will actually lead to a varus moment. So you can see on the right side there, he's got some hip collapse, and instead of his knee collapsing inwards, he gets that varus thrust. This guy was being treated for IT band syndrome. And then for a helpful test, our static alignment maybe will play a little bit of some clues there. Dynamically, what's going on? Squat, what kind of motor patterns do we do whenever we squat? When I ask someone to squat, I don't tell them how to squat because I get a lot of clues from, are they more glute dominant or are they more quad dominant? If when they go to squat, they're bending more from their knees and their knees go past their toes, they're probably more quad dominant and have a shutdown of their glutes. Whereas we get our folks that are actually doing a good sit back, like they're sitting in a chair. Those folks have good glute recruitment. When you test their single leg squat, don't just test it slow, but test it fast too. We want to perfect these movements in a slow motion, but then we need to be able to do it at a fast speed. And then treatment, address the correlated weaknesses and the mobility issues, address the training mistakes, shoe wear, static alignments, functional integration. So, and if we find that they have glute weakness, if we just give them side planks or leg lifts, is that going to translate into better running mechanics? Sometimes yes, but we really need to get into our running economy where we address the neural aspect of it and those motor patterns. And then of course our running program. And most of you guys are probably too young to remember the Nike project, but this is the initial project where they're trying to get Kipchoge to go under 2 hours in the marathon. And so I just inserted myself in front of the picture and made myself lead the pack there. So I will finish with that. Do you guys have any questions for me?
A reminder, in order to ask a question at the top, it'll say Q&A. You can click on that and then type it in. It can be totally anonymous if you want. It'll give you that option. And then as a reminder, if you've got a hop and you have something that comes up in the next, week or so, and you want to throw that question out there, we have our contact information that you got when you registered. We'll also be sending that back out to you so that you can reach out and ask any of those questions. Reminder, we take students all the time across our Confluent Health brands. Amy is also in charge of the whole student program at Sport Therapy, right, Amy?
Yeah.
You help with all of that and actively take students as well. And then, of course, in all of our brands, we have that option too. So if you're looking for student rotations and things like that, we have some great locations for you. And then those of you that are looking for jobs and residency placements and just getting into either the sports outpatient or ortho outpatient realm, then Confluent Health might have a good spot for you. So reach out if you need anything or have any questions around that. I'm not seeing any Q&A pop up just yet. We'll give them just another minute. Amy, thank you for everything. It's really palpable that you care about this stuff. And that makes it easy to learn from you too. So thanks for sharing all your expertise.
Yeah, thanks again for having me. Like I say, I get super excited about it, and so I'm sorry. I really tried to condense this into 1 hour, which is really tough for me to do. So I'm sorry if I went fast, and I'm sorry if it was a ton of information. But I am here. If you have any questions about anything, feel free to reach out.
Cool. And we do have one question that popped up in the chat. What are some exercise interventions for a runner with a bunion and pronation?
Oh, I love that. Okay, so again, that's only part of the story. So what has led to that bunion, what has led to that pronation? But again, I could spend a whole another hour on foot mechanics. But one of the things that I challenge my patients to do is I ask them to be able to spread their toes. Can you spread your toes? They're always shocked. I can't spread my toes. I've never been able to do that. And I always remind them, okay, well, when's the last time you held an infant and you see what happens at their toes? We obviously have the ability to spread our toes, but throughout time we lose that ability. And a lot of times it happens through shoe wear. We get put in shoes at a super early age, and especially the shoes with the narrow forefoot, it's going to compress those feet. And that's where a lot of times that decreased activation of those toe spreads happen. And so I will actually get them to buy those toe spreaders online, and I'll have them start wearing those. A lot of times they can only tolerate it for about 10 to 15 minutes in the beginning, but I had them try to progress to where they're wearing those throughout the night. And that gives them, that first of all, that stretch, and then it gives them the ability to start recruiting those muscles in that pattern. So I think that's super helpful. And it's also helpful for plantar fasciitis because the nerve complex is going to pass right underneath our abductor hallucis. And so if we get atrophy of our abductor hallucis, a lot of times we get scar tissue around the nerve complex through there. So we need to be able to train that system. So to answer that question, the foot exercises are helpful, but you need to find out what's led to the pronation. Is it coming from the hip, or is it truly coming from the foot?
Awesome. Thanks, Amy. Great question, Catherine. All right. Well, we will wrap it up. Shoot us any other questions you have. And we hope to see you in August for our next Excel and PT career series. We're going to take July off for the summer, and we will see you back in August. Thanks, everybody.
Thanks.